Hi, everyone. Thank you so much for joining us today. Welcome to the Essential Substance Abuse Skills webinar series. My name is Ella Driscoll, broadcasting to you from Iowa City, Iowa. And today, Avis Garcia will be presenting clinical evaluation and treatment planning. This training series is brought to you by the National American Indian and Alaska Native Addiction Technology Transfer Center. And we are out of Iowa City, Iowa. In the next couple of days, we will send out a follow-up email to everyone who attended, which will include a link to the recording, a handout of the slides, and a CEU request form. Our center is a NADAC certified educational provider, and we'd be happy to provide you with CEUs. We are currently waiving any fees for CEUs during quarantine, and when we send out our follow-up email, we'll include instructions for ordering those. Immediately following today's webinar, you will be redirected to our GIPRA evaluation. This survey takes just a few minutes to complete and asks you about your satisfaction with this event. This feedback is critical to our future work, and we really would appreciate any time that you spend giving us your feedback. You will be muted for the duration of this webinar. Please use the chat feature to ask any questions and comments, and we will address them at the end of the session. So today we will be featuring Avis Garcia. She's an enrolled member of the Northern Arapaho Nation and affiliated with the Eastern Shoshone Tribe of Wyoming. She earned a doctorate in counselor education and supervision at the University of Wyoming, and she's also a licensed professional counselor and licensed addictions therapist. For 19 years, she has been a mental health provider in the treatment of Native American youth and families. So I'm going to go ahead and give the floor to Dr. Garcia, and thank you so much for being here today.
Thank you. Okay. All right, today we're going to continue with the series of the essential skills. Today's goals and objectives are to cover the referral process, service coordination, documentation, community case management from a strengths perspective, and research. Okay, using a recovery-oriented response, it looks at the promotion of self-care and rehabilitation. So when someone comes in for treatment, if you see this bottom line, 0, where they're going into remission, where a lot of those symptoms are going away, and then this is severe, meaning whatever problems they might be struggling with. So it has a lot of ups and downs. It's not a smooth process for anyone to establish recovery. And when I talk about addictions, most commonly I'm talking about drug and alcohol use, but this also applies to any other addiction out there. Like there are a lot of process addictions that, you know, people struggle with as well, such as shopping, gambling, sex, a lot of different things. Even video gaming has become an addiction with a lot of younger people. You can go to the next slide. When I'm talking about the recovery-oriented systems of care, if you see this diagram here, in the middle would be the client. If at all possible, any family members you can get involved, and also considering the community that is available to that individual. The other services and supports you see out here in the blue circle, this is family and child care, education, housing, transportation, any legal, financial, this is where case management would come in, vocational services, HIV, healthcare, drug alcohol treatment. So being able to connect them to the services, so it does require that you become knowledgeable of all of the systems that are available in your community to meet clients' needs when they come in for treatment. The systems of care in the purple circle is the addiction services, mental health, primary care, vocational, criminal justice, veterans, the Department of Defense, health insurance, Indian health, housing, social services, and child and welfare family services. On the outside here, we have um, all the pieces that are required to establish some substance abuse recovery, such as being abstinent, getting a job, having drug and alcohol-free housing. Being drug and alcohol-free leads to reduced crime. How connected are they and what is their access? Some people don't even know where to start, so we need to help them. Retention is keeping them in the program and what their perception of care, and also trying to be cost effective in providing the services that they need. And a lot of mental health and substance abuse is provided in the community on an outpatient basis. And residential treatment is something that is well, in my area, very limited. That's often our last resort. You could go to the next slide. Okay. Now, this is the referral, and this is after you've done their assessment and you want to connect the patient with services that will benefit them. The first one here is the referral is a process of facilitating the patient's utilization of available support systems and community resources to meet their needs identified in their evaluation or treatment planning. So if we need to hook them up with the college for GED classes, or they need to get to the Department of Transportation because they need to get their driver's license, or they need medical care and they're very low income. So knowing what resources are available is very important. You can go to the next slide. You want to establish and maintain relations with community agencies, civic groups, your spiritual community, tribal leaders, other professionals, government agencies, and just the community at large. So you can refer them to other sources of help that they might be able to take advantage of. Continuing with the referral, it's to continuously assess and evaluate the referral resources to determine if they're appropriate. Is the client establishing and nurturing collaborative relationships with key contacts and community service organizations? Do they have someone they're working with at DFS, or someone? A lot of people I work with are in probation and parole, so we have to have ongoing communication with them. Interpreting and using their evaluation and patient feedback data. So being able to use their assessment and getting their input. And we're not the one running it. This is their program, so we need to make sure that we're on the same page. And giving feedback to the community regarding the resources that they deliver to your agency. I have the ones that I can think of off the top of my mind is we often have workforce services come in and they talk to people about how to look for work online, getting their resume done. And then we have a cooking program that teaches them basic cooking skills, and they get a cookbook and some things from it. Our clients really enjoy it. And now a lot of this is done on Zoom. We kind of lost a lot of those connections. And now that everybody's adjusting to the way things are now, our referrals are starting to come back together. We could go to the next slide. Continuing with the referral, you want to differentiate between situations in which it is most appropriate for the patient to self-refer to a resource and instances requiring counselor self-referral. So there's some places you might be able to tell them they can go to on their own, and then there's others that it might be to their benefit that you advocate for them and help them make that contact. So again, looking at their assessment and treatment planning materials, what have you decided needs to be, they need help with? Assessing the patient's readiness, where the patient is ready to roll with the resistance versus forcing change. So are they ready to change, or is this something they just have to do because maybe the legal system is requiring it? and educating the patient regarding appropriate referral processes. So letting them know what is appropriate services for them to be seeking. Next slide. You want to arrange referrals to other professionals, agencies, community programs, or other appropriate resources. Explain in a clear and specific language the necessity for and process of referral. This helps to ensure patient follow through. So we refer a lot of our treatment patients now to an outpatient community health center that we have a memorandum of agreement with. And this is also a sliding fee scale place where they can receive services at a very low cost or even free, but being able to use that time with them to be like, the next time I see you, you should have already contacted this agency and made your appointment. So it's helping them to make sure that they follow through. The next slide. You want to exchange relevant information with the agency or professional to who the referral is being made. This is also something important that needs to be documented in the patient's chart somewhere, that this referral was made, and to evaluate the outcome of the referral. Oh, the client did well, they did see the doctor already, they got their medications, and they're doing good right now. So it's important to help follow up on those types of things. The next slide. Again, following up, it is your responsibility to contact the agency post-referral. And sometimes we're not always able to do that. Sometimes we have someone in the agency that, can you give them a call and let me know what's going on? And so I do a lot of that. Checking with the patient to see if they were able to engage in services following the referral. So that's always good when they actually go and get the services you refer them to. To the next slide. The next is the service coordination. This is a quote that is from Dennis Banks, and I think it's a really good one. It says, "Since the beginning, Native people lived a life of being in harmony with all that surrounds us. It is a belief that all humankind are related to each other. We believe we are related to all other living species, the winged ones, the four-legged, the plant life, and the elements of life, air, fire, and water. The sun, moon, stars are there to guide us." So everything. Next slide. Service coordination is the administrative, clinical, and evaluative activities bringing patient treatment services, community agencies, and other resources together to focus on issues and needs identified in the treatment plan that was developed in collaboration and guided with the patient. So this is what we refer to as person-centered treatment that allows them to make a lot of important decisions for themselves and advocate for them, learn to advocate for themselves. The next slide. Service coordination includes case management. A lot of agencies have limited funding, such as the one I'm working in. So I'm on my staff to remember that a lot of times that they're spending with clients, they're providing case management. And that's because we don't have a case manager. So as therapists, we sometimes have to wear more than one hat and take on this role. We help the client establish a framework of action for the patient to achieve specified goals. So this could actually be, one of their treatment goals, and, outlining everything it is that they agree they would like to participate in or get more information about. To the next slide. Service coordination, again, requires collaboration with the patient and significant others, family, the TOSPE, coordination of treatment and referral services, liaison activities with community resources, liaison activities with managed care systems, ongoing evaluation of treatment progress, and ongoing evaluation of patient needs. Service coordination includes implementing the treatment plan. You want to initiate collaboration with the referral source, obtain, review, and interpret all relevant screening, assessment, and initial treatment planning information, confirm their eligibility for admission and continued readiness for treatment change, and complete necessary administrative procedures for the admission to treatment. So there's a lot of documentation, a lot of paperwork that needs to be completed and kept up to date in an ongoing process. Implementing the treatment plan is establishing accurate treatment and recovery expectations with the patient and involve significant others. Go to the next slide. Implementing the treatment plan, continued, coordinate all treatment activities with services provided to the patient by other resources, develop and maintain a community referral list, develop multidisciplinary collaborations within the community, accessible as needed, deliver case presentations, use appropriate technology to collect and interpret patient treatment information for diverse sources. So for instance, we may refer someone to the Department of Family Services to go apply for benefits such as food stamps and financial assistance. And so having that communication with that agency will help collaborate those needs for that patient. To the next slide. Implementing the treatment plan demonstrates accurate, clear, and concise verbal and written communication, making sure that we're both on the same page and they understand what goals they're going to pursue. This is participating in an interdisciplinary team building, participate in negotiation, advocacy, conflict resolution, problem solving, and mediation. Assist the patient in developing and maintaining contact, face-to-face, phone, and electronic. We like to make the clients be responsible in maintaining communication with our program, and they can use any one of those avenues. Again, documentation is a huge in doing this work. Service coordination includes consulting. Summarize the patient's personal and cultural background, treatment plan, recovery process, and any problems that might be inhibiting their progress. So I know some places transportation is a big issue, so that might be something prohibiting someone from getting to treatment. Some treatment agencies offer transportation and oftentimes they don't. Here we rely on, we have a public transportation system and a lot of our customers use it. Understanding terminology, procedures, and roles of other disciplines related to the treatment of substance use disorders. Contribute as part of the multidisciplinary treatment team and apply confidentiality regulations appropriately. Continuing assessment and treatment planning, you have to maintain ongoing contact with the patient and involve significant others. A lot of times when my clients come in, we have them do a release of information so that we are legally able to communicate with a brother, a mother, anyone that might be there to support them so that we can share whatever information they specify. Understand and recognize the stages of change and other signs of the treatment process. Making appropriate changes to the treatment plan to ensure progress toward treatment goals. Sometimes that needs to be changed. Describe and document the treatment process and progress and outcome. Continuing assessment and treatment planning, use accepted treatment outcome measures. One that I like to use is the GAF score, where we do the daily living skills assessment. I often use that in measuring outcomes for treatment improvement. So the global assessment of functioning is calculated from the daily living assessment that gives you the GAF score now. And so we're looking for their score to go up, and that would show that the patient is improving. Continuing care, relapse prevention, discharge planning with the patient and involve significant other. So treatment isn't just temporary and you're done. A lot of times when they finish an outpatient program, continuing care is the next step. You know, it might be once a week meeting. Maybe they have a relapse, so we bring them in for relapse prevention skills, and then discharge planning. And like I said, if you can get family involved, that helps them to have more support. Again, documentation of all the service coordination activities throughout the continuum of care. Applied placement. Applied placement continued to stay in discharge for each modality on the continuum of care. The next slide. Documentation. So many colors from which to choose from. And documentation is something that we do throughout the treatment programming. It's something you will do every day with the clients that you work with. Let me change to the next slide. One quote that I've always heard is, if it isn't documented, it didn't happen. So it's important to document all contact, phone contact, your sessions, the groups that they have. And sometimes they have emergencies and crises, so you need to be able to document that as well. I often tell my own staff that, because they have questions about what to write and how to write, and I tell them, I was trained to think of whatever I'm writing in there could go to court. So that's often what I use as my guide in documenting my progress notes. Next slide. Documentation covers a lot of required paperwork from the beginning and all throughout the treatment process, beginning with the screening and intake process. An assessment is scheduled, so the client completes an assessment with a therapist. Once the assessment report is completed, a treatment plan is made with collaboration with the patient so that they can have a lot of input into what it is they're willing to do as part of their treatment. We have to do clinical reports, clinical progress notes. This documents their progress towards treatment goals. And when they're preparing to complete their treatment program, we have to complete a discharge summary. So some of our people prematurely drop out. They just stop coming. A lot graduate, some transfer, and some people go between different levels of care. Maybe things got worse for them, so we had to look at increasing their treatment, maybe moving them to a residential program, and then coming from residential back to outpatient treatment. And any other patient-related data that might be helpful. You can go to the next slide. Documentation. This demonstrates knowledge of accepted principles of patient record management. Choose timely, clear, and concise records that comply with regulations, and document the information in an objective manner. Go to the next slide. Documentation is about protecting the patient's rights and their privacy and confidentiality in the preparation and handling of records, especially in relation to the communication of patient information with third parties. These apply to federal, state, and agency regulations regarding patient confidentiality, request, prepare, and complete release of information when appropriate. And I shared with you just a little bit earlier that sometimes they want their girlfriend to call or their mother to call. And so when we don't have that release of information, we can't provide any information or even let them know that they are a patient. And it helps reassure the client that their information that they are providing is kept confidential and that we don't release anything without their written permission. Oftentimes they are referred by court systems, probation offices, the Department of Family Service. So whatever program is referring them for that assessment, it's important to get them to sign a release of information so that we can collaborate with that agency that referred them. Documentation, prepare accurate and concise screening, intake, and assessment report. So generally, this information is important to look at when you're completing an evaluation on someone. So we would want to get their history of substance use and abuse. When did they start drinking? How long? How much? When did they stop? Have they ever stopped? Have they had any problems trying to stop? Physical health, anything that they may be struggling with physically that they may need referral for. Psychological information. A lot of times in the mental health field and substance abuse, issues aren't identified right away. Sometimes it happens later, but if they can provide you with this information, it can be really helpful if they can tell you if they know what their diagnosis is and what types of treatments they've had and how are they currently managing whatever issue they may be struggling with. We need to get social information, where are they working? What kinds of things do they like to do for entertainment? History of criminality. Do they have any law issues in their background? What is their gender identity, their cultural orientation, and anything else that might be helpful. Next. Record treatment and continuing care plans that are consistent with agency standards and comply with applicable administrative rules. The biggest one is the informed consent. Document in a timely, clear, and concise manner. If you're doing any work with any client, you should document at that time and make note of if you were doing an interview, if this was their session. So everything needs to be clear and understandable. Recognize the importance of recording treatment and continuing care plans. You want to record patient progress in relation to their treatment goals and objectives. You want to use appropriate clinical terminology, review and update their records. Every agency has their rules or procedure of how they manage up-to-date records, and the records that we do in our agency are 90-day increments. So we check on them at least once a month and have a meeting with them to see where they are in achieving goals that they set for themselves. Preparing clear and legible documents and documenting any changes in the treatment plan. So if the client completes their intensive outpatient program and now they're going to continuing care, that takes them down in a level of care. So we call that a transition plan and we document that. Next slide. You want to prepare accurate and concise discharge summaries. This is a very important document that a lot of even the programs that provide us with funding from the government for services require us to have the discharge summaries that goes into a state data system here. Of course, for client confidentiality, we don't use their name. We create special ID numbers for them. So the charge summary should include the patient profile and demographics, what symptoms brought them to treatment, their diagnoses, the interventions that were used, what worked, what didn't work, any critical incidents they might have had while in the program, progress towards their treatment goals. Did they accomplish their treatment goals? Is there some, maybe they still need to continue with? What has been the outcome? Their aftercare plan and what their prognosis is, things looking pretty good for them. Are they going to require some ongoing assistance or continuing care with maybe a vocational rehab program, and any recommendations that you might have that shows you covered all the bases and making sure that this person that's discharging, we have covered everything with them. The next slide. Document treatment outcome using accepted methods and instruments. So you want to gather and record outcome data, incorporate outcome measures during the treatment process, and recognize that treatment and evaluation should occur simultaneously, and appreciate the importance of using data to improve clinical practice. So when I'm looking at outcome data for some of, a lot of the clients that we provide services to now, we may be looking at their attendance. A couple of our counselors have their own curriculum, so they require patients to complete certain projects that fulfills their treatment program. And we also look again at the DLA. We do ASAM updates on the clients weekly. And sometimes, like I said, we need to work on getting their treatment levels. So if they, again, most commonly where I'm at, they complete outpatient treatment. And so then we have to document that they went from that level of care to the lower level of care. And we can go to the next page. Community case management. This is from a strengths perspective. I really think in the substance abuse treatment field, and especially working with the Native American population, and as a personal choice of mine, I really think a strengths-based perspective. I use it in my supervision. I use it when working with clients, and I like it because it really, I feel like it helps build the client's self-esteem. Go to the next page. As I said, some agencies don't have case managers. I've seen agencies where they have a whole room full of case managers. So sometimes, like I said, we have to do more than just being a therapist. So the strengths-based perspective to case management, this is from Siegel in '95. So seeks to encourage the patients to become more deeply involved in their own treatment. And this doesn't always happen from the beginning, because a lot of the time they're not there because they want to. But over time, once they realize that they need to be there, they begin to become more involved. Simultaneously assist the patient in learning how to acquire and retain resources that will support their recovery. And then this is also from the book by Skinstad and a few other researchers that have the book on counseling theories and techniques for rehabilitation health professionals. So that would be a good book to check out. You can go to the next slide. The strengths perspective, the 5 principles whereby the case manager facilitates identification of the patient's strengths, abilities, and assets. So we used, in our agency, we use what is called the SNAP. So that is their strengths, their needs, what their abilities are, and what their preference are. So that's what our accrediting agency requires SNAP to be done on all of our patients that we see. So being able to focus on their strengths and abilities and assets. So what do they have that they know they can apply to whatever goals it is they're going to be working on? Assist the patient in focusing on their goals, identifying alternatives, and locating resources by encouraging the patient to identify his or her own needs. And these needs change continuously. And we just need to be prepared to help them obtain the information or get referred to a program that might be helpful to them. You can go to the next slide. The strength perspective serves as a primary advocate for the patient and coordinates all their relevant services, encourages positive and proactive identification of resources in the patient's environment, including community agencies and social support. For example, what kind of friends, families, and neighbors, helping them find places to associate that are more positive to their recovery if they're working on sobriety. Works with the patient in the community to maximize the fidelity of the provider's perceptions and the patient's experiences. So has to be something that they're willing to engage in. Could go to the next slide. And then we have the research. Case management research. Comparing research results across case management-oriented programs is difficult because of the way the case management concept is defined. More study is needed regarding the degree to which the type of program influences retention. So in mental health, there's ongoing research and being able to get more information. If you see this book here, the date of this was published was in 2004. So we're in 2021. Things change all the time. So it is important to keep up on the latest information that is coming out. Here are some sites for some research information. SAMHSA is one of my favorites. You can get a lot of information there that is free. It has a lot of the tips and taps, and I was looking at one today. I believe it's tip 27. Yeah, tip 27 is on treatment improvement protocols. This one is on case management that is free from SAMHSA, and there's several others that are really good. NIDA is the Institute on Drug Abuse. The Prairie Lawns Technology Transfer, National Institute on Alcohol Abuse and Alcoholism, the Office for Addiction Technology Transfer Centers, the Iowa Substance Abuse Information Center, the American Counseling Association, the American Psychological Association, the Association for Medical Education and Research, the College on Problems of Drug Dependence, and the National Council of Problem Gambling. The one I don't see here, you can go to the next slide, is NADAC, and that's for addiction professionals where most obtain their certifications, but they have a website that they offer a lot of good information on. Okay, when we're looking at the presentation, here's a summary of everything that we covered today. Sorry, it seems like I went a little too fast, but we'll have some time for questions here at the end. Any questions?
Hi everyone. So if you can post questions in the Q&A or in the chat, that would be so great. We can kind of have a chat discussion. So I do have a couple comments. Someone said the GAF score was eliminated in the DSM-5.
It is. It is. And it used to just be in the DSM-4 on a page, and it went from 100 to 0. And that was based on the patient's ability to function. And now it is called the DLA. It's the Daily Living Skills Assessment. And what we use, it looks at 20 parts of that patient's life and where they're functioning, like is managing money, dressing appropriately for work, do they have stable living? There's several different questions that we address, and we rate each item. There's 20 items on a scale from 0 to 7. So 0 would be that they're having serious difficulties there, and a 7 would be performing at their very highest. So the DLA 20 is where we calculate the GAF now. It's no longer in the DSM-5, but it is required. The DLA 20 also helps you to identify medical necessity for treatment plans. There are insurance agencies that require the person providing the services or the agency to demonstrate medical necessity for people. So maybe we could say, this person's substance abuse is so severe. It shows here, based on all these problems, and their score would be indicative of somebody who is in need of services. So that score ranges from also very low to up into, I think the most you can get is a 90, 99 on there. But most of the people in treatment are usually in the low to mid 50s in functioning. So it does show that there are a lot of issues the client may be struggling with. And again, like I said, medical necessity, that's what I like about using that.
Yeah, definitely. Have another comment. I think it's really important on the ROI that you specify what information you want released to the respective agency and or other resources involved with the client.
Mm-hmm. Any agency that is involved, some of our clients are required, like probation and parole, is they will release information. They have no choice on that. But then with these other agencies and significant others even, yeah, what you can release. Some of our people have parents that are making them come to treatment. So we want to have a release of information if that person is over the age of 18 of, you can talk to my mom about this. So there are, it is important to be specific, just like the person stated, as to what and who will get what.
Yeah. Would you say that using person first language is important in promoting a strengths perspective? What advice would you provide to a substance abuse counselor and other staff who do not use person first language and tend to refer to clients as addicts?
Oh, yeah. I never refer to my clients as addicts. It's up to them, I feel, of how they choose to identify themselves while they're in recovery. And I think when they changed the DSM-4 to DSM-5 and we went to substance use disorders, we got away from diagnosing that person as dependent or an abuser. So it's changed it to a disorder, which has verifying tendencies. But I don't know. I can't honestly tell you how I feel, how important it is. I think it's important to focus on their strengths because these are things that they know they're good at and what they're able of doing, what resources they have to access. So yeah, I would never, I would strongly recommend that nobody label someone as addicts, and that's up to the client to choose that for themselves.
Mm-hmm. And would you say it's true that, like, I'm just curious for myself, like, would you say it's true that like clients can pick up on that really quickly? I feel like that would be such a huge treatment barrier if they felt any sort of judgment and, you know, just another person judging me, that sort of thing. So it really almost becomes a treatment barrier, it sounds like, if you don't use a person first language.
Yeah. I agree with you that it would create a barrier, like even for mental health issues, like even with this COVID, some of our clients felt that was a stigma for them if they had COVID in their family, and they don't want people to know, you know, so we have to do our best to respect, you know, their wishes. And even with mental health and not just substance abuse, that there's still that stigma out there that people don't like other people to talk about that. And I think for those that are really that make that connection to change their life in their treatment, that they reach that point where they're comfortable with saying, yeah, I'm a recovered addict, and I've been clean for however many years. And I think it takes time for them to identify on their own how they will present themselves and whatever issues they might have. And then some don't want to tell anybody at all. And we have to respect that.
Yeah, definitely. We have a comment, love her style, to the point and fact-based. We'll look forward to the slides. Awesome. Yes, lots of compliments on the presentation. We have one more. Avis, I know some parole officers and other reference agencies, when referring clients to treatment, want them to go directly to residential without even being assessed. Do you find this a problem with these resources? Example, tribal courts and penal systems. It's getting better, but still creates issues with treatment providers.
It creates a big problem, and one of the ways we've addressed it here in the state is being able to make that connection with our courts and the judges that are there, and the probation officers, and educating them that and if a court says they're sending that person, that could make them liable for the payment of that person's treatment services. Yes, there may be clearly a need, but it's better that they recommend they seek counseling, not and say, oh, you need to go to treatment, because not everybody needs to or wants to. They have to be assessed by someone, and a court or any agency can't just say what they want someone to do.
Mm-hmm. Definitely. If anyone has any more questions, feel free to put them in the chat box. But
yeah, I had one judge, and this is the county detention center that borders our reservation. And he told me that keeping people in jail was his treatment. He said, I know they can't get to treatment, so I just keep them in jail. And I'm like, well, they're just sitting here. You're not providing treatment in here. And some jails actually create access to some type of treatment. I know the jails here in Cheyenne do have AA available for those that want it. They'll send a counselor in for those that want it. So they try to provide some of those services in the jail.
yeah, that's amazing that, you know, hopefully more places will do that. Hopefully that is becoming the new standard. That sounds amazing.
Mm-hmm.
Can you say more about cultural issues, like perspectives that substance use issues are manifestations of historical traumas among American Indians, and the importance of taking these into account in the prevention, treatment, and recovery?
That's a really good question. I am working, well, I have a presentation that I did before. I was asked by the state to present on Native Americans, and I have always had this one thing that I don't like, that people who are non-native and don't really know, again, I say I speak for my culture where I come from, they don't understand what my tribal people have gone through with this historical trauma. Um, and I feel that a lot of the Native Americans are judged negatively because of other people stereotyping Native Americans as less than and can't do anything and what's wrong with them and they just drink and, you know, all these negative things, which is why I like the strengths-based perspective. I'm like, these people that are making those statements don't know our people well enough to focus on the positive things. And I'm working on a series that I'll be presenting. I'll be doing about 5 trauma sessions, and one of those will get real specific into the intergenerational trauma and how this uh, ties into substance abuse and substance use, and how it can be genetic and it can be passed down, and working with communities to in treatment on the reservation. I've actually presented this intergenerational trauma topic more than once, and it's just real uh, interesting to see some of the clients react real positively to that and be able to share their family stories of experiences from historical trauma. From my tribe, we had the Sand Creek Massacre here uh, between Cheyenne and Colorado, because our homeland, where we preferred to live, was in Denver. And so the government's way of trying to get rid of us was, you know, not only displacing us against our choice, but also attempting to kill our tribe. You know, they went in and massacred them early in the morning, and that has had a huge effect. I am a descendant from the Sand Creek Massacre. I had family that was there, and my own grandparents had to go through the boarding school traumas. So that really shapes a lot of people's thinking and the way they live life as to how they've managed to cope with that trauma. And for some people, especially the people that I've worked with, I just feel that some of these people feel there's no hope.
Mhm.
And a lot of people may be struggling with issues that turn to drug and alcohol use as a way to escape. You know, they don't want to feel. Some of that stuff is very painful. And working with substance abuse all the years that I have, I really feel that now that we're more aware of the issues that might bring about or lead them to self-medicate, are what we really need to try to help them understand and learn how to manage and cope. And some people need medication. And for those, you know, I let them know, you know, it doesn't mean you have to have medication, but we could help you with some coping skills. For, you know, there's still a lot of trauma on the reservation, I feel. I mean, like I said, I grew up in a home where uh, alcoholism was pretty, you know, using alcohol, I thought, was just what everybody did. And so, and then I seen it, you know, I just feel like it just contributed to a lot of the traumas I've been, I guess I could say I'm a survivor of, or a victim of losing people to drug and alcohol. And that this historical trauma, all these people that are here today, you know, it just goes to show that you have a vested interest in the people that you're working with, and that you want to improve your skills and taking your skills to the next level so that you could help people. And so I'm glad that we're able to do these webinars so that people can, you know, take a look at their own community and how they can address this, because it takes more than one person to help. And I tell people, you don't have to be a licensed counselor to help someone. I mean, if you could just learn those basic skills a lot of times they just need somebody to listen to them and hear them. And
Mhm.
our people are adjusting to going to treatment, but Native Americans are probably the highest dropout from any type of treatment or any type of therapy. But I've seen, well, I continue to go there from time to time. One treatment program that I feel the lady from her years of experience has done a really good job of addressing that culturally, to where uh, the patients can kind of pick and choose what they want to do as part of their treatment program. And I see that when they're
Okay.
given option that satisfies the requirements, they're more willing to participate.
Yeah, definitely. And that's amazing that you can, make materials like that about trauma, about historical trauma, especially, like you said, from the strengths perspective, where it's not just this is what happened, and it's not just a tragedy, but it's also like turning that into like we are still here, and just the legacy of resilience and strength. And even like today, just seeing that, I think that really is so positive, especially for people who have felt ignored or can't talk about it, or why do I feel this way, and
Mm-hmm.
it's a really, really positive thing. Yeah, for sure. Someone said, we finally got the tribal courts to put in court orders to a comprehensive biopsychosocial and following the recommendations of the counselor. This was very helpful if you can work with these tribal courts regarding this issue.
Mm-hmm. Yeah, it is. And yeah, sadly, there's still people out there that don't understand even the court program that I work with. Uh, we're fortunate to have a judge who is in recovery himself, so he could speak to our court participants of, he knows what it's like, but he's also a model for them as a judge, that he still lives that lifestyle. And sometimes I think he doubles as a counselor in the courtroom, but we don't have too many judges in that position. So
Mm-hmm. Yeah, definitely. All right. Well, if anyone has any last questions, we might be able to end early. Yeah. Um, I just wanted to say thank you again for everyone who joined us today. And thank you so much, Dr. Garcia, for just another incredible session. For everyone listening right now, if you're on our listserv, please keep an eye out for our Monday event emails, or please feel free to visit our website to see our upcoming events with Dr. Garcia. After the call ends today, you will be redirected to our Gipper survey link. And this is just a short survey that gives us feedback on our events and helps our center a lot. But with that, thank you so much for joining us, and I hope everyone has a great rest of your day. It's so good to see you in the new year, and wishing you all a safe and healthy 2021. We made it. All right. See you, Dr. Garcia. Thank you so much again.